My name is Lieutenant Lisa Wood. I'm with Miami-Dade Fire Rescue's Venom Response Unit. This is a unit that is primarily responsible for snake bites in South Florida and actually throughout Florida and the country. We maintain the largest Antivenom Bank in the country and the only one that's for public use. We have a number of different antivenoms, as many as we can get. We buy antivenoms from all over the world. In addition to dealing with bites and other animal calls within the county, we also do education programs, and this is one of them. This is Envenomation Management for healthcare professionals. And we're going to talk about the identification of venomous snakes versus non-venomous, and talk about what you can do for people who are bitten by snakes, venomous or non-venomous. Sometimes knowing the difference is really the key. This is who we are. There's actually 6 people in our department who are licensed or certified to do this. We have to maintain a venomous reptile license from Fish and Wildlife and also have experience in treating bites. This is our vehicle. We drive a Ford Excursion. We have a lot of different equipment because we respond to a lot of different kinds of calls. We do the pythons, which are primarily in Dade County, not so much in other counties, but they could be. Venomous species such as snakes. We also run on stings from various animals, spider bites, scorpions, and the bees, which are a whole class unto themselves. We also do large and small animal rescues. We provide antivenom for vets when needed. We occasionally deal with alligators if they're of immediate threat. Again, our bank was created in 1998. We are the largest in the country. We actually have more than 48 antivenoms to cover: snakes, spiders, scorpions, and marine life. And at this point in time, we are 24/7 availability. How antivenom is made, this is just a quick and dirty version. The venom is extracted from the snake or spider, depending on which case you're talking about. It's purified, and then it's inoculated like a vaccine into either horses or, in the case of the North American pit viper antivenom, sheep. The animal mounts an immune response and produces antibodies for the venom or venoms that are injected. The serum is taken from that animal. The red blood cells are put back in. It does not harm the animal in any way. The antibodies are filtered out of that serum, and they are made more compatible with humans, less allergic to humans, by either acid washing or breaking them into particles. And then that is either freeze-dried or put into solution, and that's what the antivenom is. Crofab is what's pictured here, and that's the polyvalent. In other words, it does many species of North American pit vipers. Objectives of this program are: know who to call. Venom 1 is our unit. Our office or cell non-emergency number is 786-331-4454. That will ring through to whoever's on duty. If no one's on duty and we're on call, that will ring through to the fire alarm office, which is 786-336-6600, and they can track us down. They'll track down somebody if it's an emergency. Poison control is also an excellent source of information for snake bites. 1-800-222-1222 is their number. That will get you local poison control wherever you call from. We're going to talk a little bit about how, why, and where bites happen, recognize the general characteristics of venomous versus non-venomous species. Sometimes just knowing that the animal is non-venomous is a priceless bit of knowledge. Identify signs and symptoms of medically significant envenomation, and then the management of that envenomation. Snakebite season, April through October. In South Florida, it can be year-round. Most of bites occur during the day. In South Florida, where it's really, really hot during the day, not even the snakes like to come out when it's that hot. And we will have bites that happen at night. If people walk around in flip-flops, they're in the dark, they step on it, that's enough irritation for the snake to bite. 70% of bites are males age 14 to 40. About 70% involve the upper extremity, usually the dominant hand. The person is trying to pick up or kill the snake. About 50% of our bites are probably preceded by "dude, hold my beer." There's 7,000 to 8,000 bites a year reported in the U.S. There's, I'm sure, a significant number that go unreported. Of those, maybe 5 to 12 are fatal, and those are going to be people that fail to seek medical treatment or fail to seek it in time. 15% of bites are considered dry bites. In other words, the snake bites and does not inject venom. Snakes can meter their dose, particularly the older snakes, the adult snakes. Baby snakes tend to give you what they've got, but an older snake doesn't want to waste venom on something it can't eat. They put a lot of biological energy into producing that venom, and they don't want to waste it. And wasting it on people is very low on their priority list. They don't want to bite, but they will if they feel threatened. So 15% of bites are dry. You may have puncture wounds, but you're not going to have the significant swelling, bleeding, significant pain that you would have with an envenomating bite. Of true envenomations, the great majority of them are not going to kill the patient. 85% of bites are mild to moderate in severity. If the patient did nothing, they would survive. They may lose function or parts, body parts. They may end up with an amputation, but they're probably not going to die from it. 15%, however, are critical. In the state of Florida, we have 44 species of snakes. There's only 6 that are venomous, and there's only 4 that are statewide in distribution. And those 4 are the Diamondback rattlesnake, the Pygmy rattlesnake, water moccasin, those are our pit vipers, and then we have the coral snake, which is an elapid related to cobras and mambas. Their venom is neurotoxic, so we're going to talk about them separately. The pit vipers are the first things we're going to talk about the snakes. As far as identification, they have elliptical pupils, so they have cat-like eyes. They have pits in their face, which are actually heat sensors. This allows them to hunt in darkness. It also allows them to bite through a bag. The pits are very, very sensitive to heat, and they can detect heat gradients, and they know what's warm and what's food and where you are. If you're in the dark, they know where you are. And then, of course, they have the fangs that fold in, fold out as needed. In the picture of the little skull, you'll notice that there's actually fangs folded back against the upper mandible there. They change their fangs out every 6 to 8 weeks, so you can't just defang them and make it so they can't bite. You also might have more than 2 puncture wounds. If they've got actually 3 or 4 fangs, the 2 new ones are ready, but the 2 old ones are still there, you may have multiple puncture wounds, and that's something to look for. If you see 4, it still could be a pit viper envenomation. As far as identification in the field, if you can see any of those things on the animal, you are way, way too close. Say for distance pit viper identification, these things you can see from a distance is that they have very large triangular heads. They have very heavy bodies. In other words, you're never going to look at a venomous snake or a pit viper and say, that's a long, skinny snake. It's going to be very, very wide-bodied and heavy-bodied. And they have keeled scales, which is like the vein of a leaf that runs down the center. It causes them to have, their skin looks rough. It doesn't necessarily feel rough, but it looks rough. The reason they have the big triangular heads is because of the plumbing. And they have a venom gland in the cheek area, and that's where the venom is produced and pumped from. It goes through the duct and out the fang, and the fang is just like a hypodermic needle. Pit viper venom, what does it do? Well, it's designed to kill prey. It's not designed to hurt people. It does if they bite you, but it is not designed to kill you. They do not want anything to do with people. They would prefer not to deal with people. So most snakes just want to get away from you, and pit vipers are no different. It is more potent in young snakes. It causes severe swelling, tissue death, bleeding problems, renal failure secondary to other damage. It can remain active in the system for 7 to 10 days in the absence of antivenom. So if a person is riding out a bite, they are going to be feeling the effects of that bite for 7 to 10 days before they start with the healing process. Sometimes venom is used as the therapeutic agent. It's not all bad. There are cancer drugs that use snake venom. There are stroke drugs that use snake venom. And there's lots and lots of research currently going on with many different venoms to actually produce products that are going to help people. Signs and symptoms of envenomation, we're going to see slides of all this. Pictures actually do a lot better than this slide will for words. But punctures, immediate pain and swelling, persistent bleeding from the puncture wounds, and it's not gushing blood, it's just oozing, 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 sometimes for a day or 2. Blisters, blood blisters, ecchymosis or redness, fasciculations. With some of the bad bites, like the eastern diamondback, you may see fasciculations, which is like a wave-like movement of the muscles. Unusual taste. If the patient says, oh, I've got this metallic taste after being bitten, that is potentially a very serious bite. Nausea and vomiting can be projectile. The venom actually travels through the lymph system, and so it has to go through the lymph nodes, where the lymph nodes try to filter it, and the lymph nodes become tender, proximal to the bite site. And then later stage, of course, is necrosis or tissue death at the bite site. First one we're going to talk about is the cottonmouth or water moccasin. This is probably the most common bite that we see. Cottonmouths are very self-assured snakes. Some people call them aggressive. They are very defensive for sure. Cottonmouth is sunning himself, or water moccasin, same thing, is sunning himself, and you want him to move, he may or may not move. If you continue to bother him about moving, he is probably going to strike at you. The reason they're called cottonmouths is their defensive posture is to coil up and sit back and open the mouth, and that's why they call them cottonmouths. It's like white inside, so that's how they got the name. This is a plaster model of a typical cottonmouth. They are black when they get bigger, but you can kind of appreciate the rough appearance of the skin, the wedge-shaped head. Okay, you've got the fangs here. The eyes are very difficult to see because of the eye stripe that's on the animal, and also because the pit vipers have an angry eyebrow, and it kind of shrouds the eye, makes it hard to see. The thing about the water moccasins is they don't look like this when they're young. When they're young, they're brown striped. Here's a picture of a juvenile and an adult. The adult is almost black. You do notice he's in that defensive posture. I don't think he has his mouth open yet, but he is getting there. You'll also notice the tail, how it tapers down very abruptly to the tail of the animal. That's one of the differences between them and a non-venomous water snake that you can see pretty easily out in the field. Now, the babies are born with this brown stripe pattern, and anyone that knows what a ball python looks like, a lot of people think that these look like ball pythons. We've had numerous bites from people picking up baby moccasins thinking that they are ball pythons. Sometimes they don't bite right away, but eventually the reason we're seeing them is because they have bitten and they've been envenomated by one of these baby snakes. So just be aware that they look very, very different, and if you have a call at this type of snake, this size of snake, they will bite and they will deliver as much venom as they have. This is a water moccasin envenomation. This was a 15-year-old boy who had the snake at home, and he was messing with it, and he taped its mouth. It bit him. It couldn't let go because of the tape, so he was actually squeezing its head, trying to pry it off his leg, and that's his thigh. He had a good outcome. He got numerous vials of antivenom. This is about 40 minutes into the bite, but you can appreciate the bruising and the marked swelling. Those markings on his leg are swelling in pain, and also the dripping blood there. And that kind of is what a typical bite will look like after 40 minutes or so. This is another water moccasin envenomation. This person chose not to have antivenom administered for I don't know his reason, but he didn't want it. And you can see that by the bottom right slide, he had a fair amount of tissue death there. And I believe that he ended up losing his finger from that bite. But you can see the blood blisters that formed, and also, again, the persistent bleeding. This is a copperhead bite, but it's very good to illustrate the blistering that can happen, and also the swelling. And these bites are very, very painful. Pygmy rattlesnakes, these are the smallest of the pit vipers. A large one is 24 to 30 inches. But again, for his length, he's got a heavy body. A 20-inch pygmy rattlesnake is going to be as big around as a garden hose, a good-sized garden hose, where a 20-inch non-venomous snake is going to be more about the size of a pencil. So you're not going to see this snake and think, oh, it's a skinny snake. They're a heavy-bodied snake, even though they're small. They do have a tiny little rattle that they will rattle to let you know that they're angry or that you're in their space, but it's so small that it's very difficult to hear. And they are very well known for biting first and asking questions later. These are some bites. The two bites on the hands both were a result of people reaching down to pick up potted plants. I don't know what store they were at, but the pygmy rattlesnakes had taken up residence in the potted plant from the nursery, probably. It probably didn't happen at the store. and they got scared when they got transported. They stayed put, and when the hands came down to pick up the plant or take it out of the pot, the snakes struck out. You know, they felt threatened, they strike, and we've had several bites that happened that way. This is an untreated envenomation. This kind of just shows the necrosis and what happens if you just leave it alone. Eventually, some part is going to fall off. I guess it's better than losing your whole thumb. The eastern diamondback rattlesnake is probably the most dangerous snake that we have here in South Florida. They're few and far between, but in rural areas and areas that have a lot of cane grass or wild land type area, pine land or swamp even, you will possibly run across these animals. They can get up to 6 or 7 feet long. They can deliver an incredibly large dose of venom, and they can deliver it very quickly. These snakes, the venom from these snakes, because of the volume, is extremely dangerous. Signs and symptoms vary according to the geography of the snake, where it's from. Down south, there's a lot of problems with coagulopathy or bleeding issues from this. You know, it kills the clotting factors in the blood and the platelets. In more northern areas, it's more pain and swelling and tissue damage. And some of it depends on the person's who's bitten, the victim's body chemistry and how it reacts with it. It might affect two people differently, but they are a very, very dangerous species. This is the plaster model of the eastern diamondback. You can see the diamond-shaped pattern. You can see very clearly the wedge-shaped head. It makes it look like it has a pencil neck. It's got the pits in the face and, of course, the slit pupils. But again, you can appreciate the rough skin and the heavy, heavy body. If someone gets bitten by a snake and they go, oh, we think it's a diamondback rattlesnake, well, was it a fat snake or a skinny snake? Oh, it was a long, skinny snake. And you know, the diamonds were kind of like squares. Well, that was probably a corn snake or a rat snake of some sort. They're not likely to describe a rattlesnake or a water moccasin as a skinny snake. This is an envenomation from an eastern diamondback. This particular snake did not produce a lot of pain and swelling. It did have some bruising there and some persistent bleeding. And the guy knew what he was bitten by. He saw it and was very adept at identifying it. However, this can be a problem at the hospital. If the doctor is looking for a lot of pain and swelling and he doesn't see it, he may or may not be likely to give enough antivenom to cover a very severe envenomation. And this patient did, in fact, end up with coagulopathy, which was treated, and he was fine. But the doctors are looking for this. And this is actually a western diamondback envenomation, but you can see how much more swollen the leg is. Western diamondbacks produce a lot more swelling and tissue damage than the easterns. So a big difference between looking at that bite, you don't think it looks that severe, but actually systemically it is. This bite was severe, and it looked severe. This is another western diamondback envenomation, and again, this is more so you can appreciate the blood blisters and the swelling that was involved there. Viper, pit viper versus Elapids and non-venomous species. The non-venomous species and the Elapids have a thin body, and they have a round pupil. The Elapid that we have here, Elapids are cobras, mambas, taipans, and in South Florida, we have the coral snake. Actually, the coral snake is all over the southeast U.S. There's probably 60 to 100 bites a year from this animal, this species of animal. The coral snake, the rhyme is red on yellow kills a fellow, red on black friend of Jack. Some people find it easier to think of a traffic light. It changes from yellow to red, you stop. If you see yellow touching red, you stop. This is the only skinny snake, native skinny snake, that we have to worry about in Florida, okay? All the other venomous snakes are going to be fat. And of course, this one has the pretty obvious coloration. All the other skinny snakes are good. Elapids, coral snakes, cobras, mambas, they have small teeth. They have front fixed fangs. Their venom is neurotoxic, so it may cause a little bit of pain and swelling, but the main issue is going to be neurotoxicity. Because they have such small teeth and small fangs, the injection may be very shallow and signs and symptoms may be very slow to appear. Plus or minus local pain and swelling. And the tooth marks may not look like fang holes. They may be just scratches or a scratch. But if the person says, well, it was a red, black, and yellow snake and I have a scratch and I don't feel good, they probably do have an envenomation. There's an old wives' tale that says that the coral snake has to grab you in the web of the fingers and chew on you in order to envenomate. That is not true. They can bite through calloused skin. They can inject venom very quickly, and even a scratch can actually produce a significant envenomation. The coral snake venom has the neurotoxic properties. It can be 12 to 24 hours delayed onset. We've actually seen it up to 36 hours onset, which if the patient goes to the hospital and the doctor's used to treating pit viper bites, and if a pit viper dry bites, the hospital will watch you for 6 to 8 hours and say, go home, you're fine. If they do that with a coral snake bite, they may end up with problems because the person still could exhibit signs and symptoms. We had a friend of the unit who milks coral snakes or extracts venom from coral snakes have a bite, and it was actually 24 hours before she actually had signs and symptoms. And when she did, she had been having signs and symptoms before that, but she didn't realize that she was actually hallucinating. And that took a whole day where she thought she was getting treated, but it was all a hallucination. And then when she started having difficulty breathing, she called and we said, no, you got to call 911. She did. She went to the hospital and then she got treated. So she was fine, but the onset of signs and symptoms was very significant with her. Signs and symptoms, nausea, vomiting is very common, particularly with an acute envenomation, one that is a lot of venom injected deeply, relatively speaking. That patient is going to be sick very quickly. Ptosis or drooping of the eyelids, slurred speech, drowsiness, flaccid paralysis of the extremities. Eventually it paralyzes the bulbar nerve and you get a copious secretion of thick saliva and you become unable to control that. You can't swallow, you can't talk, and you can't raise your hands. So it's very hard to express the fact that you're choking to death. These patients, while they may look like they're unconscious, are not. They can hear and understand everything you're saying. So be very careful about if you're discussing the case amongst yourselves that you're not saying things that are going to be scaring the patient further than they already are. The signs and symptoms are the venom binding to nerve synapses. And once it's bound onto that nerve synapse, it is not coming loose. So the antivenom is actually to get the venom that's still circulating versus to reverse signs and symptoms. That's going to be very difficult. This is a coral snake. This is a typical looking coral snake. You've got the red touching yellow. You've got the yellow band around the head, black nose. Red on yellow, just go with that. No, it's got a black nose or a red nose. The problem is that people can look at the snake and it's very difficult to make the rhyme match the snake if you're looking at both of them. So, and if it bites you and leaves, I guarantee you're going to have a hard time remembering what the pattern was. This is again a coral snake. Not all of them look exactly like this. Nature is really good at throwing curveballs. In deep South Dade and in the Keys, you have animals that look like this where they have very, very little yellow. And the yellow is, it's almost a darker sort of color that's kind of hard to recognize. It doesn't look like your typical brightly colored coral snake. The further back on this snake is just red and black. So something to be aware of. This is also a coral snake. This animal was captured in Martin County and they didn't know what it was. They took it to a wildlife sanctuary and they recognized its behavior as coral snake-like, and they did a sort of a close-up study of the head scaling pattern, and it was a coral snake. But as you can see, this snake does not even have a stitch of red. This snake is an albino eastern coral snake. We've had people show us pictures of some of them from South Dade. This happened to be caught in Deltona. And the people caught it and took it to a fire station. They didn't know what it was. They thought it was somebody's pet because it's an albino snake. It was 40 inches long. It's unusual for an albino animal to survive that long in the wild because they're so brightly colored. They usually get picked off by predators, but this one was evidently good at hiding till the people found it. And they took it to the fire station. Fire station didn't recognize it. They called animal control. Animal control didn't recognize it. They called a trapper, and the trapper took it to a serpentarium, and the serpentarium says, that's an albino coral snake. So beautiful, beautiful animal. And in all of the changing hands, it didn't bite anybody, which was very lucky. As far as caring for a patient or a friend or yourself who gets bitten by a venomous snake or a non-venomous snake, keeping the patient calm. If you can identify the animal, great. If it's non-venomous, even better. Remove rings and other jewelry. If it is a pit viper, you're going to have some pretty rapid onset of swelling. And if they've got rings or other jewelry, that's going to become a constricting band. It's going to be too painful to get off, and it's probably not going to come off after a while without being cut. Activate venom response. At least give us a heads up if you can. If we're all the way on the other end of the county and we need to get back to the office, or we may need to get back to the office, it's better for us to have an early false alarm than to be on the other end of the county and all of a sudden we're needed urgently at the hospital. The hospital actually has to order the antivenom for us to ship it, but it helps to know ahead of time if you guys are dealing with a bite or we're going to be dealing with a bite. The sooner we know, the better. You can cleanse open wounds. Try to get the venom off the skin if there is venom leaking out. Mark the bite site, circle it, and put the time on it. If it turns out to be nothing, sometimes it's hard to find. If there's no fang marks, which happens, some little scratches, that we have a hard time seeing it. Or if it becomes that real heavy bruising, sometimes it's hard to see the fang marks. So circle it, write the time, and then just mark the zones. Track that spread of pain and swelling. And if the pain goes farther than the swelling, mark both and say P and S with the time on it. It's significant to us, the information, because if we've got a bite that after an hour is swollen up to the shoulder from the finger, that's a very significant envenomation. If it's swollen up to the first knuckle after an hour, that's going to be a less severe envenomation. Good to know. Loosely immobilize the affected limb below the heart, neutral position, and then beware of anaphylaxis, particularly if the person works with venomous snakes for a living or has worked with them, because that constant low-level exposure to the snake's venom a lot of times will produce people who are anaphylactically allergic to the venom, and they can breathe it, they can get an aerosol of it. If they're cleaning and water splashes back on them, they can have a reaction to it, or if it's injected, like with a snake bite. Hopefully these things didn't happen. We don't want tourniquets on these bites. That causes its own set of problems with byproducts that build up in the tourniquet limb, and then releasing that, of course. If it's got a tourniquet on already and it's been on there a while, it's probably better to get medical direction on that one. You may or may not take it off because when all that byproduct is released, you're going to have a whole other set of problems. But the tourniquet is also, for the venom itself, is going to keep the venom concentrated in that limb, and it's going to cause the limb to be even more vulnerable to the venom. Ice, same thing. Vasoconstriction is going to make it more vulnerable to the venom. The venom extractor, the little suction device that actually is supposed to pull the venom out of the tissue, that one's questionable because it does cause a bruise, and that bruising allows the venom to be more damage to the skin. Electroshock, no. No alcohol. If the patient's already had alcohol, it's going to be tough enough to decide whether the slurring of the speech is from the alcohol or from the snake bite. Certainly more won't help. Don't cut and suck. That doesn't work, and damaging that tissue further is just leaving it open for a longer healing time and more infection. Don't try to catch or kill the snake. That is a really good way to be a secondary victim. If it's a native pit viper, it doesn't matter if it's a baby water moccasin or a pygmy rattlesnake. It's all the same medication. Doesn't matter. If they already have the snake, call us. If the snake is contained and alive, let us know. Dead snakes can still bite. Something important to know, the head of a dead snake can still bite, and if it bites you, it's not going to let go anytime soon. It's going to inject everything it has because it's just a reflex action. So if the snake is beheaded, don't pick up the head. Just you touching it is enough to cause it to have a reflex bite. Pre-hospital ALS care, of course you're going to treat anaphylaxis per protocol, and then rapid ALS transport for any known or suspected envenomation. IV access, good IV is really important, preferably opposite the affected side. However, if the person's been bitten in both hands, do the best you can. Notify the receiving hospital as soon as you can. Notify us if you can. Monitor vital signs and the progress of the pain and swelling very carefully. Minimize patient activity. For an Elapid bite like a coral snake or a mamba or a taipan, a lot of times these keepers who keep these animals, these are exotics, they're very dangerous animals, and they will actually work with an assistant, and if they're bitten, the assistant knows to put this pressure mobilization bandage on. If you get there and the patient has one of those pressure mobilization bandages on, don't take it off. What it's doing is it's slowing down the circulation of the lymph, which is how the venom is going to travel through the system, and it's buying that patient time. It's keeping that venom in that limb, because remember, these animals cause neurotoxic effects, not tissue toxic effects. And by doing that, it's buying that patient time to get antivenom on board. Without that, they could die in 20 minutes or an hour. With it, they can last several hours, enough time to get the antivenom on board. So if you see that pressure mobilization bandage on there, don't take it off. And implore the doctors not to take it off. Looking at the bite is a lot less important than that pressure mobilization bandage. So just let them know that it's very important to stay on there. Now, with the exotic bites, we need as much detail as possible on the ID of that animal. If you get to a keeper's place and they don't tell you exactly what bit them before they pass out, it's going to be very difficult to know which antivenom that we're supposed to bring. If they say cobra, that's really not good enough. We need to know if it's a monocled cobra, a spectacled cobra. If they give you the scientific name, that's fine. We'll figure that one out. We know what the scientific names are. But king cobra, monocled cobra, Indian cobra, those are all different antivenoms. So we need to know which one it was. If you wanted to do a pressure immobilization bandage and medical control and your protocols allow that, what you would do is you would wrap that with an ACE bandage, and you can use a splint, and you would wrap it about as tight as you would for a sprain. You don't want any compromise of distal circulation. You still want good cap refill. You still want a good distal pulse. It's just a mildly snug wrap to help keep that lymph from moving around too much. You don't want to decrease blood flow, just that lymph. So you start at the bite site and wrap proximally all the way to the main part of the body. You don't want to do that with a bite that's going to swell or is actively swelling. Some of the cobras cause a fair amount of swelling and would not lend themselves to this procedure. The main thing is if you see this on a patient already, don't take it off. Snakebite triage, activate venom response, ABCs frequently. The neurotoxic patients cannot really tell you that they're having trouble breathing. They may not look like they're having trouble breathing because they also have this paralysis. So keep an eye on them, and if you start hearing gurgling or they start drooling and they can't swallow, sometimes they can nod or shake their head. You can say, "Can you swallow?" And if they shake their head no, you need to think about protecting that airway because they're not going to be able to. Reassure the patient, minimize activity. Again, remove rings or other jewelry, mark the bite site, good IV, progress of pain and swelling. Keep the affected area immobile, extended and elevated if you can. Again, the pressure immobilization, leave it on, and if you need or have time to call poison control, they're a great resource. This is just a quick scale of severity of snake bites. Dry bite is going to be very little wound or no wound, slight pain or swelling that goes away. May go away in an hour. It's just very localized. Mild is pain and tenderness, edema at the bite site, a little affected outside the local area. Moderate would be pain, tenderness, redness, edema beyond the bite site, and maybe some systemic effects like a mild coagulopathy, but you're not going to see that until down the line. And that would be a hospital diagnosis anyway, and we're not going to see that in the field. Severe would be intense pain and swelling of the entire extremity, severe systemic effects and coagulopathy, and probably recurrent coagulopathy. And life-threatening, of course, is worse than that. The pain of a pit viper bite has been likened to having your hand held over an open flame, stabbed with an ice pick, and slammed with a sledgehammer all at the same time. And that happens within minutes of the bite. So if someone is bitten by a pit viper, they are going to know beyond the shadow of a doubt that they are in trouble very quickly. If they were bitten by a pit viper and none of that stuff happens, it was probably either a dry bite or it wasn't a pit viper at all. Labs and monitoring, this is more for the hospitals, but the main things here, particularly with eastern diamondbacks, are going to be those clotting factors, the prothrombin time, the PT, the PTT, the fibrinogen, and platelets. And those need to be checked as soon as possible after the bite so that there's a baseline there, and then repeated every 6 to 12 hours. Once the envenomation appears to be under control, those lab tests need to continue every 6 to 12 hours for a couple of days, because it may take a day for that recurrent coagulopathy to come back and hit them really hard, and by that time you're playing catch up again. So you want to catch that really early, and that's actually happened in hospitals where they go, oh, the patient looks really good, they stop doing blood work, and then the next day or a day and a half later the patient is having major problems again and they didn't catch it. So every 6 to 12 hours, repeated. Liver function tests, those others are just all pretty much standard fare if you're in the hospital for anything. And a toxicology screening, because sometimes people say they got bitten by snakes and actually they're just looking for pain meds. We've had those calls too, where people stab themselves with a fork and say, oh, I got a snake bite, and they'd hit it with a hammer and make it all bruised. Actually pain med seekers. Non-venomous garden snakes. These are important because a lot of times what people get bitten by are these non-venomous garden snakes. And of course, a lot of people think any snake that bites, you're going to end up dead. So they get bitten by a black racer or a little rat snake and they think, oh my gosh, I'm in trouble now, and they go to the hospital. Non-venomous snakes have small round heads. They have round pupils. Their eyes are usually prominent. You can see them very clearly, whereas the pit vipers have the shrouded eye with the eyebrow. Non-venomous snakes, you can see their eyes very clearly. They have long, slender bodies. If somebody says, I've got a long, skinny snake in my yard, unless by some strange chance they have an exotic that got away from somebody, which to my knowledge has never happened as far as somebody finding one. Long, slender body, native snake, not dangerous unless it's this guy. Various colors and patterns, which we'll look at a few of the more common ones. Now these snakes all have teeth and they will bite. They have no claws, they have no legs to kick, they can't scratch. All they can do is bite and musk or poop and smell bad. That's all they've got in their arsenal, so that's what they use. This is a red rat snake or corn snake. They're very, very common. Generally they come out at night to hunt. They'll eat lizards and amphibians, they'll eat mice, they'll eat birds, they'll eat eggs. They love eggs. So they can be in the trees, they can be up on a door jamb. They'll climb up the stucco wall in the corner there and then get up on the door jamb and eat the lizards that are up there eating the bugs that go to the light. Very, very common. They tend to be docile if you treat them nicely. They'll generally sit in your hands and not bite. But if they feel like they're threatened, they'll rear back like the guy in the picture here, and they'll strike and act all mean. And they just want you to go away. They'll shake their tails. They'll rattle those tails, and people think, oh, it's a rattlesnake. And they see the square pattern on the back, and they look at it sideways, and now it's a diamondback rattlesnake. Everglades Ratsnake or yellow ratsnake, like a Dijon mustard colored with the dark stripes that run lengthwise on the body. They actually do get about 6 feet long, and they're pretty impressive. They generally will not let you handle them without biting. Southern ringneck, they only get about 10 inches long and less big around than a pencil. But because of that red ring around their neck, people think they're baby coral snakes. They're not dangerous at all. They can bite and draw blood a little bit, but they're just not, they're harmless. Black racers, these are probably the most common thing that people see in their yards. They can range anywhere from a gray-green to a deep black color. They're smooth, they're long and skinny, they're very, very fast, hence the name racer. They're very defensive, and if you grab them in the middle of their body, they will bite you several times before you can stick them in a bag. They'll shake their tails to act like rattlesnakes. They'll rear back and strike. They're out during the day, which is why there's such a problem, because people see them a lot. If you wear your fire gloves, you're good. You know, you can grab them and they can't bite through a fire glove. When they do bite, it's startling, but it really doesn't hurt. It doesn't tend to get infected or anything. You just wash it off with soap and water and you're good to go. But black racer is very, very, very common. That's probably the bulk of our snake calls, non-venomous snake calls just around the county. Baby black racers look very much like a pygmy rattlesnake, but the pattern is finer. It's a smaller pattern, and they're skinny. These guys are anywhere from 12 to 18 inches long when they're babies and colored like this. A 12 to 18 inch long pygmy rattlesnake is going to be the size of a small garden hose. These guys, thinner than a pencil. So again, long and skinny is good. They will rattle their tails and they will strike. But they're very, very common, very, very harmless. Banded water snake, there's several different species of water snakes in South Florida, and unfortunately for them, they look very similar to water moccasins. They can have sort of a banded pattern like the adolescent water moccasins before they're black, but after their juvenile coloration, they sort of go through this phase where they look very similar to the banded water snake. Banded water snakes, the other water snakes, they'll all flatten their heads out when they get defensive, and that looks like a big triangular head. They have the rough skin and they have the heavy bodies. There's a few things that you can look at to tell the difference. One, if you can see their eye clearly from a distance, you're looking at a water snake. Water moccasins, it's very difficult to see their eye. If you can see the eyeball clearly, it's a water snake. Water snakes will generally retreat when you get about within 15 feet of them. They're out of there. They're back in the water. They swim underwater. Moccasins tend to swim with their heads up out of the water. Water snakes underwater. Not hard and fast rule, but general rule. The water snakes also have a scaly lip line. Here's one flattening out his head. And they're hard to tell apart. I don't blame anybody that can't tell these apart because they are very similar. Okay, here's one. You can see the scaly lip line, that sort of smiley lip line. They don't have that eye stripe that the moccasins have, and you can clearly see that eyeball. And here's a comparison slide. At the top is the bodies of them. The water snakes, the tail tapers down very gradually. Water moccasins, it's a very abrupt tapering down to the tail. Again, if you can see the eye, it's non-venomous. At the bottom pictures, you can see the angry brow, how it shrouds the eye. It's very hard to see. Compared to the water snake, you can see the eye. You can see the eye stripe on the moccasin. There is no eye stripe on the water snake. And the water snake has the scaly lip line. The moccasin's lips don't show up at all. Exotics, moving along. There are lots and lots of people who keep both native and exotic venomous snakes, or HOTS as they call them, in the state of Florida. The majority of them are licensed and they are careful and they are very good at what they do. Still, accidents can happen, and a lot of times 911 will be called, and rightly so, because a lot of these animals, the venom is extremely dangerous. But again, we need to know what species was involved, not just cobra. Hopefully there's somebody there, and most of them have protocols, and they'll actually have a written protocol with the name of the animal, what the venom effects are, what antivenoms work, where to find us, where to get a hold of us for the antivenom, and that sort of thing. And the really good facilities have that for each species that they keep. This is a cobra envenomation. He does have some swelling there. That is his abdomen. He was bitten on the abdomen, and you can see the fang marks there and a little bit of necrotic area around that. This was a monocled cobra envenomation that was one of those that we didn't know exactly which type of cobra it was, and it was sort of trial and error with antivenoms until about 8 hours after the bite. It was discovered which animal it was, and it was a monocled cobra. And she did recover. She was on a ventilator at this point in time, but she did recover once the right antivenom was administered. I believe she did lose part of her hand from that bite, though, and that was tissue damage due to delay in treatment. This is a spectacled cobra envenomation it's about a 6-week-old injury at this point. It was treated promptly and properly, but this is how bad the venom is. She had a hole in the ball of her thumb that was weeks and weeks and weeks in healing. This is a patient that we had from right here in Palm Beach. She was bitten by a spectacled cobra. She called 911. She was treated immediately by the crew on scene, transported to the hospital. Miami-Dade Fire Rescue actually flew up with air rescue, flew the anti-venom up, so she was treated fairly quickly. In the picture here was just when Lieutenant Mullen got there, and she could barely open her eyes. She could not speak, and she actually had some fluid buildup in her mouth from not being able to swallow. But by sitting her up and letting that just come out by normal gravity, she did not have to be put on a ventilator. But she was getting to the point where if there had been much more delay in treatment, she probably should have gone on a ventilator to protect her airway so that she didn't end up with an aspiration pneumonia. The picture on the right of her hand was about 6 days after the bite. She had been released from the hospital, and her hand had significant swelling and pain, and she actually ended up with an infection in there, which is somewhat unusual, but you can really appreciate the swelling in her hand and imagine how painful that must have been. This is a gentleman who was envenomated by Taipan. His assistant, or it may have been his wife, put that pressure immobilization bandage on his arm, and at this point in time, 4:42 in the evening or in the afternoon, he was maintaining on a nasal cannula. He was doing okay. He couldn't move. He could still swallow. He was maintaining his fluids okay. He was getting administered antivenom. This was also 9/11/01, which was kind of a really bad day to have to transport antivenom from another state. But it was one of the only planes in the sky that night. Antivenom had to be flown in from San Diego, I believe it was. I know it was California. He did survive. The pressure immobilization bandage, I was saying, is very, very important. He was doing fine with it on. A doctor came in and took it off, and this is the same gentleman within 3 hours. And you can see he was bleeding from every orifice that you can see there and every orifice that he had. He even had a little healing wound on his eyebrow that was bleeding. Would he have been like this had they not taken the pressure immobilization bandage off? We will never know. It's possible. But his situation became very grave shortly after it was taken off. So, we believe that it was having a positive effect in this case. But he did survive. He was out of the hospital, I think, within 3 days. So things can look very bleak and still be okay. Again, he looked to be unconscious. In this picture, he was because he was sedated. But in the previous picture, he looked to be unconscious, but he could hear, and he remembers very well all the discussion that was going on around his bedside, including the fact that he heard people say that they thought he was going to die. So you want to kind of be careful about what you say. A snake bite is like a heart attack. It's like a stroke. Time is tissue, okay? We are here as a resource for you. Please, please, please use us, call us if you have an animal that you need identification on. If you suspect an envenomation or you just need to know, give us a call. 786-331-4454 is our office number, or you can email us at mdfrantivenom@miamidade.gov. Either way will get us. Those are non-emergency numbers, of course. My name is Lieutenant Lisa Wood. I really appreciate you watching the presentation here, and hopefully you've learned a lot. Thank you so much.